Please welcome Dr. David Koehn.
Good afternoon, everyone. I will be co-presenting this with my postdoc fellow, Dr. Brittany Nelson, and the three primary objectives that we'll attend to throughout this conversation is, one is we will review the history of post-traumatic stress disorder and kind of look at what the current treatment modalities are and some of the current trends, both from an inpatient and outpatient service. We'll also look at how this might impact intimacy and the wellness of the patient's ecosystem. And we will kind of architect it around the constructs of system thinking and viewing it from a holistic approach to wellness. Before we get actually started, I think it's really important that we kind of operate from the same sheet of music and look at the definition of trauma. In particular, what we're most interested here is in psychological trauma. As you can see on the slide, that it's particularly a function of one's mental model or psyche, and that psychological trauma can be an outcome that's occurred based on some emotional or physiological state. It can be either acute, induced, or it can be chronic based on periodic episodic interactions with an event that causes one's personal well-being to be compromised. It's very subjective in terms of who ends up with psychological trauma. Not everybody who gets introduced to a given trauma reacts the same way. And as you can see in the bottom set of the description on this particular slide, that certain protective factors do entertain the ability for a person to potentially counteract some of the elements related to one's difficulty in dealing with trauma. Now, we're going to kind of speak from all those three objectives, but over-architected is the fact that we're going to view it from a systems approach, where, as you can see from looking at it in an ecosystem, all the various different facets that get involved in a particular solution to what is occurring. In organizations, you can see that a variety of different elements interact with each other to produce either a healthy or an unhealthy state. And when we see post-traumatic stress disorder, we're going to kind of look at it as a structural system that has problems that are associated with multitude of interactions that compromise the individual. In particular, when we see it from a systems thinking standpoint, we're interested in really looking at the interactions between the different elements that impact the individual system in itself, as well as the cyclical nature of the dynamics that occur around it. So when we consider the cyclical nature of what happens from a systems thinking perspective and looking at post-traumatic stress disorder, I want to illustrate to you a simple dynamic slide that kind of looks at it as a nonlinear relationship. When you see this particular slide, it is very overly simplified. It could be very complexly dealt with, but the important element here is when you view it from a systems thinking perspective, that you understand there are do loops and interactions between different events that occur within a given system, and also that there are delays before you see really the outcome of what's really occurring. So between the traumatic event and the evidence of post-traumatic stress disorder, there's typically a delay factor. Between the evidence of post-traumatic stress and the treatment, we also can see that there could be a negative feedback loop in which the treatment itself could exacerbate the evidence of the post-traumatic stress disorder. And even if the treatment were successful, there is a delay before you actually see success, and before the success actually evolves into some degree of resiliency that the individual can utilize within the overall system that he operates, to which on some future traumatic event they may be able to be more successful in. You'll also notice that interacting with the traumatic event is the series of protective factors that can actually minimize or eliminate any evidence of post-traumatic stress disorder in this particular dynamic. Now, we're going to review the current literature regarding post-traumatic stress disorder, and Dr. Nelson will take you through some of the important points that we found in our review in terms of looking at this.
So we're going to do just a brief review of the literature. And the first consensus that we found among researchers is that while PTSD is a universal phenomenon, it happens across all different cultures, that sometimes symptom expression can be culture bound. Some of these symptoms can include persistent intrusive memories or dreams, avoidance of reminders through detachment, emotional numbness or avoiding activities, and increased irritability, anger, or vigilance. The next commonality among all of the research was that PTSD is actually reported in minority of populations. It's reported in 15 to 25% of the population in post-disaster situations. Only 4% of British soldiers developed PTSD after serving in Iraq. It rose to 6.9% for those in combat roles, and among reservists, the rates were a little bit higher, averaging around 6%. A study of more than 10,000 people, including police and construction workers, who came to the aid of staff at the World Trade Center on September 11th, found that 3/4 did not have long-lasting difficulties. They did not qualify for PTSD. And even when you take into account that sometimes symptoms can be delayed, only 8.5% of the responders from the World Trade Center experienced difficulties later on. Approximately 15 to 20% of women have been victims of rape, and close to a third of these women report current rape-related PTSD or clinically significant depression or anxiety. Most individuals exposed to traumatic events do not develop PTSD or other psychological problems, indicating that there are important unanswered questions about how these problems are produced. So we need to examine why some individuals are resilient and see if we can repeat some of that in therapy in order to bolster resiliency after PTSD diagnosis is made. PTSD has a strong impact on the ecosystem, so not just the individual, but the ecosystem in which they live. PTSD has been associated with marital and relationship difficulty, aggression toward partners and children, sexual dysfunction, and emotional distancing. Because PTSD affects the family so profoundly, this book was created by a licensed clinical social worker named Beth Andrews. It's called Why Are You So Scared? When a parent has PTSD, children often feel confused, scared, or helpless. They're affected by the disorder that their parent brings home. This book explains PTSD and its symptoms in non-threatening, kid-friendly language and is full of questions and exercises that kids and parents can work through together. PTSD also has a relationship with intimacy. PTSD is implicated in marital problems such as low marital and sexual satisfaction, elevated divorce rates, and partner violence. In military couples, deployment separations are said to undermine opportunities for positive connections and require significant adaptations in the communication processes of the couple. So for military couples, marriage is already a stressful relationship. Deployment creates added stress on that stressful relationship, and sometimes military couples can't recover from it. Internationally speaking, anywhere from 1/3 to 1/2 of all women, when asked directly, report being a victim of sexual violence, with the impact of this violence also being great on the victim's significant other. PTSD can be highly disruptive to both individual well-being and marital and parenting relationships. The arousal cluster of PTSD symptoms promote expressions of anger and hostility toward others, so spouses and children, while the emotional numbing cluster is linked to loss of intimacy and withdrawal. A review of more than 100 studies of Holocaust survivors and international veterans found that their spouses reported elevated levels of anxiety, depression, hostility, and somatization. There's recent Department of Defense data indicating that 3.6% of all service member marriages ended in divorce in the fiscal 2009 year. You compare that with a decade earlier, and the incidence of divorce has increased by 1%. PTSD also has a domino effect on veterans. Military veterans with PTSD divorce at higher rates than trauma-exposed veterans without PTSD. PTSD is also linked to increased relationship discord, poor relationship adjustment, and elevated psychological and physical aggression towards partners. Every year from 2004 to 2011, war was the leading cause of death in the U.S. military. However, in 2012 and 2013, suicide caused more deaths than war, heart disease, cancer, homicide, and accidents, which leads one to wonder whether or not PTSD played a role in these suicides. Milken and colleagues reported a four-fold increase in reported interpersonal problems from the first to second waves of assessment in their longitudinal study over 88,000 soldiers who served in Iraq, which goes to serve the research proving that PTSD symptoms can appear later in life. They don't always appear right after the event, but that they can appear later. Sayers and colleagues found high rates, actually more than 75%, of family difficulties among veterans recently returned from combat who screened positive for mental health problems in a VA outpatient clinic. Patients who have mental health problems are also more likely to rate family difficulties as one of their struggles when returning from deployment. In a study of recently returned male veterans, PTSD symptom severity was inversely related to intimate relationship satisfaction. As severity increased, relationship satisfaction decreased, and vice versa. This last slide, or this last bullet point, says wives of combat veterans reported higher levels of marital distress when they perceived their husbands experienced low levels of combat exposure, and their husbands reported high levels of PTSD symptoms. However, when their wives had accurate perceptions of their husband's combat experience, their PTSD symptoms had no association with wife relationship satisfaction. So when wives have an accurate idea or portrayal of what their husbands have gone through, the relationship satisfaction is not as directly influenced as when they underestimate the trauma their husband has experienced.
So, given all that research data, it becomes quite obvious the need for wise systems in the treatment of post-traumatic stress disorder. In particular, it's apparent that a psychodynamic therapy approach, independent by itself, has actually adverse effects. So when you look back at that simple, cyclical, nonlinear diagram I illustrated to you, it actually exacerbated the post-traumatic stress disorder.
Individual treatment for PTSD is simply not effective. And one of the more promising treatments that has empirical data to support it, this treatment is described as cognitive behavioral conjoint therapy for PTSD. It's designed for couples where one or both of the partners has PTSD. It's a 15-session protocol which treats the couple as a unit using 3 different stages. The first is psychoeducation and safety building. The second is confronting avoidance, enhancing relationship satisfaction, and improving communication. The third is cognitive interventions addressing relationship problems and symptoms of PTSD, focusing on maladaptive thoughts around the trauma. This intervention treats the couple and not just the individual.
When we look at group dynamics therapy and effect on post-traumatic stress disorder, we notice that numerous couple and family treatment strategies have been developed, but few have been really studied as today. One particularly looked at the disruptions on the family system caused by trauma and post-traumatic stress disorder symptoms, and the second focused on target reparations on the family dynamic and the decrease of stress to the system, borrowing largely from couples and family treatments, marginalizing the treatment of post-traumatic stress itself.
One of the most commonly cited studies was Ford and colleagues. It was done in 1998. I know it's a little dated, but it was cited numerous times in other research. They studied the application of family systems therapy in 26 Operation Desert Storm veterans who had been deployed to the European theater and requested family systems treatment as compared to a quasi-control group of 13 veterans and their spouses who did not request treatment, and 62 other veterans from the same unit who were assessed 15 to 18 months after their demobilization. The veterans who were given family system therapy were able to resume functional levels and reduce the risk of long-term psychosocial impairment. So even though sometimes PTSD takes a little bit while for the symptoms to appear, the veterans that went through family systems therapy where all aspects of the system were addressed we're less likely to experience PTSD, even delayed.
Other implications in the family systems area: when family units are broken or roles are transformed by disaster, therapy can help the new post-disaster family to become a resource for surviving family members, enhancing the sense of control and definition of self. Any problem in one member is also a family problem. Recognizing this contextual reality, humanitarian assistance program volunteers have often incorporated elements of family theory in the treatment approach that is taught to local clinicians.
So continuing from the last slide, EMDR treatment teams that are sensitive to the family system issues, they appear to have a definite advantage in teaching EMDR across cultural divides. Furthermore, when they rely on local clinicians to deliver the EMDR, so clinicians that are already immersed into the specific culture of the population that needs to be treated, it increases the likelihood that family issues and sensitivities will be raised, will come up, and will be addressed in treatment. Similarly, narrative therapy, research in narrative therapy suggests that there is value in helping families to aid in reconstructing a child's trauma narrative to reduce shame and guilt. Oftentimes a child, they need their parents to be a part of treatment, and reconstructing the narrative to come up with a story that the family can carry on and can support and can encourage the child with will help alleviate PTSD symptoms in the future.
Continuing, it's obvious in reviewing the literature so far that looking at it from a systems perspective is vital for the potential success of treating post-traumatic stress disorder. In particular, family contextual factors such as positive family support, social support, healthy coping skills, and stable family functioning are all protective factors against the development of post-traumatic stress symptoms. Wells suggested that resilience evolves by helping the family to view the trauma as a shared and conquerable event. To help them reach this goal, therapy teaches families how to establish healthy patterns of attachment by modeling psychological availability and responsiveness, warmth, active listening, acceptance of individuality, and healthy negotiation of rules and responsibilities.
Engaging the partner of the PTSD patient is important. It's vital. So while the data on couples and family treatment is scarce, the theoretical basis for its use in the treatment of PTSD is strong. The application to a military population is compelling. Returning service members often feel like they don't belong, that they're misunderstood, and that they're alone. Engaging the partner in the family is a natural area to intervene. It can increase feelings of acceptance and belongingness, help family members to understand the veteran's experience, and illustrate to the veteran that they have the support of their loved ones.
So it's obvious that support systems are truly essential to success in treating post-traumatic stress disorder. Societies that have resources and choose to use them to shore up the infrastructure quickly and effectively will buffer their populations from increasing levels of post-traumatic stress disorder. For children, the family is the infrastructure. Therefore, when a family is intact and can access the resources essentially to meet the needs of the child, the incidence of post-traumatic stress disorder for children will be lower.
Family ties are critical to support the structure of PTSD. When disaster disrupts other social supports, the family ties assume increased importance. When the family itself is the locus of loss, the place of family in the survivor's identity may well become the focal point of trauma. When somebody is lost from the family system, all rules and roles shift accordingly, and it's helpful to have the client with PTSD be able to navigate those stresses with support.
Given the fact that we've kind of reviewed much of the literature that kind of supports the importance of looking at it from a systems perspective and more intimately from a systems thinking approach to enabling and growing and developing a positive, healthy lifestyle around the inability of others to deal with post-traumatic stress disorder, we have found that there are two basic treatments that are generally considered to be extremely or usually effective in the treatment of post-traumatic stress disorder. One is the narration of trauma memories through kind of like a systematic desensitization approach, and the other is an emotional focus or emotional regulation intervention, much like dialectic behavior therapy. There are three other treatments that are rated as top second-line interventions, those being cognitive restructuring, education about trauma, and anxiety and stress management. Given that these are best practices, it's also important to realize that we do not walk away from using a systems approach to dealing with post-traumatic stress disorder. There is no strong agreement about what periods that are expected for overall duration of treatment, nor the time periods for initial or latter phases of work. Although research demonstrates that those with post-traumatic stress disorder substantially improve and therapies lasting between 9 and 12 weeks, the survey responses suggested a longer treatment courses for complex post-traumatic stress disorder. This goes back to the systems thinking slide, where there are delays in the system before you actually see success. There was consensus that life stressors and poor social supports were the greatest risk factors for relapse, and that presence would warrant an extension of treatment. The information suggests that some consideration should be given to the incorporation of interventions that focus on managing stressors and building social supports. Given this set of information that Dr. Nelson and I have provided you, and with some food for thought about viewing it as a systems or a holistic and systems thinking approach to things, we would be interested in you actually chatting with us and providing us some feedback on what you consider to be the best practices that you have found to be helpful in working with post-traumatic stress disorder. Some of the sources that we have used throughout this presentation are these that you see on the slide. Here are some others. And third, here's the last set that we used. At this point, we're ready to entertain any questions that you might have, and we'll let our sponsor ask us some of the questions that you might have generated throughout this presentation and see if we can address them.
Okay, hi there. Dr. Koehn?
Yes.
We have a question. What are your thoughts about trauma-focused cognitive behavioral therapy?
Could they clarify what they meant by that? Because one of the slides that I shared earlier addressed the question of narration of trauma memories. Is that what they were talking about, or is it something else?
Perhaps that's the only portion of the question I see.
My approach to it is more from a systematic desensitization approach to dealing with trauma. There's no way I would reintroduce the trauma in full scope, or I would do it in a series of steps and allow them to be able to handle the fears, anxieties, and reenacted nightmares that they might have in relationship to it, and teach them the techniques associated with being able to counter it. That would be my approach to the whole thing.
Okay, is EMDR a recommended intervention?
Some of the colleagues I've talked to about that, they've had a lot of success with it. I personally haven't done it. Dr. Nelson, have you used it at all?
I haven't, but I have done therapy in conjunction with an EMDR specialist, and I think it depends on the resiliency of the client. At times I've seen great success, and at other times I've seen them deteriorate if they're not really committed to treatment and going back and continuing to work through those unpleasant feelings.
Would you consider trauma-focused CBT as a form of narrative therapy, and would that have the same form of mixed results with the level of appropriateness in PTSD children?
That sounds like a mixed bag of a question. Obviously, DBT is all around your ability to regulate your emotions and be able to handle your emotions in a more therapeutic way than you were able to just on your own. I've found that DBT is very value added in terms of all the different techniques and tools that you use to help people regulate their emotions over time in dealing with that. So I found that very advantageous, including dealing with children.
So we have from Bernard Bidell, I think. Can you talk more about the research findings on the specific use of EMDR?
Sure. What they found was that when EMDR is provided by a clinician, a local clinician who was, present during the disaster or is integrated into part of the community, that EMDR can be more effective. And kind of what they hypothesized was that the reason it's more effective is that it increases the likelihood that family issues are going to be brought up in an EMDR session, and that they can be more fully addressed by a clinician who is sensitive to, the nuances of that particular community. So EMDR, it can be effective even without using that, but when you use local clinicians, it's really an asset, and they can provide more culturally sensitive therapy. Whereas, bringing in a disaster team who's kind of been trained in EMDR and they're moving from a different area to provide services, that it's not as effective as if that disaster team moves into the area, trains local clinicians, and then leaves the local clinicians in place to provide the disaster relief services.
So you talked about family support being helpful when processing PTSD with children. What's your reflection of working with children who do not have a supportive family network?
Not that I'm not addressing the question, I'm rethinking if there is no infrastructure support system, then surrogate support systems need to be found that can provide a trusting and enabling relationship with that child. And once that's developed, bring them in to be part of the equation in helping them deal and work through their post-traumatic stress disorder.
What was the second helpful strategy in dealing with PTSD again? Somebody just wants to clarify that.
Emotion-focused or emotion regulation interventions.
Okay, thank you.
Similar to DBT.
More like dialectic behavior therapy.
Bill Martin is saying, I have found more body-centered approaches to be effective, including imaginary and EMDR.
I've seen great efficacy with centered. I think that can't involve more aspects of the system, more of their impact, more of their environment, and create more of a supportive understanding. They're still going to feel alone, in navigating that trauma. At times, the therapeutic relationship can kind of act as, part of that community. But even with the body work, I think it's important to include avenues within the community, other, like Dr. Koehn was saying, surrogate support systems if they don't have one at home, to bolster them, because they, we don't see them every day. We only see them once a week, maybe twice a week, and so, really kind of bolstering that avenue for them to heal outside of therapy.
From Chantel B, it says, have you found animal-assisted therapy to be helpful with victims of trauma?
Absolutely. We here at Sovereign Health in Fort Myers are introducing equine therapy as well as dog therapy, and the impact of that support is unbelievable in terms of their interactions and the way they are able to resolve some of their mental model problems that they're having. So absolutely.
Okay, thank you. Any known connection to birth trauma?
I'm not familiar with that. Are you, Dr. Nelson?
No, I'm not.
We'll have to research that a little bit more.
Okay. How do you determine which family members are appropriate to include into the treatment?
I'm sure there's some major thought that's related to that, but even I believe all family members should be involved as a part of the infrastructure support, even those that may have their own issues going on. Because if all you take is the ones that have a healthy dynamic, you're missing out on the impact of what might happen for those who do not have that healthy dynamic and how to basically deal with that particular set of symptomatic problems as it relates to the individual's problem. So you have to look at all parts of the family dynamics, whether they're positive or negative.
Okay, so at this time, we're actually going to conclude the webinar. So any questions that were not answered, I believe Ravi put in the chat that you can email your questions to webinar@sovhealth.com, and those questions will be answered. Again, I want to thank you all for your participation.